All right. Well, it's 12:01, everybody. We're going to go ahead and get started. I want to thank Dr. Ladd for his willingness to teach today. We are very honored to have him. He's an experienced surgeon, and I think each one of us will definitely learn a little bit more about taking care of our pediatric patients from a surgical standpoint. So I'm going to do a brief introduction and the disclaimer, and then I'm going to do our pre-test poll, and then I'm going to let him take it away. So Dr. Alan Ladd is a tenured faculty member of the Department of Surgery at the Indiana University School of Medicine. He earned his medical degree from the Indiana University School of Medicine in Indianapolis and received his general surgery training and subspecialty training in pediatric surgery also at the Indiana University Medical Center. Since completion of training in 2002, Dr. Ladd has been an attending surgeon at Riley Hospital for Children, at IU Health, and various other metropolitan hospitals with children's services in Indianapolis. Dr. Ladd has strong academic interest in undergraduate, graduate, and postgraduate medical education. He has served numerous roles in medical education at the IU School of Medicine and currently serves as the clinical instructor for several medical school elective courses. He currently serves as program director for Pediatric Surgery Fellowship Program. In 2020, he assumed the role of division head for the Pediatric Surgery Division at Riley Hospital. Dr. Ladd leads outreach efforts for surgical care in the northeast portions of Indiana through clinics in Muncie and Fort Wayne to improve access to surgical care. So we are very blessed to have Dr. Ladd with us today. I'm going to go ahead and read the disclosure just so there's no question about any outside interest. This presentation is intended for general education of medical professionals and is not provided as medical advice or a substitute for personalized advice from a medical doctor. The presenter has no financial interest or ownership in any company or product contained herein or relevant to this presentation. The presenter has received no remuneration, goods, or services in relation to this presentation. This presentation is based upon the evidence available in print or online as of the date of the original presentation. So in order to get started, we'll go with our first poll. And here it is. We'll give roughly 1 minute to complete this. Ten seconds. And I'm going to close the poll. All right, take it away, Dr. Ladd. Thank you so much.
Okay, well, let me work on sharing my screen, make sure I get this right. This is always the most uncomfortable part, is sharing the wrong screen. Can you see just a single slide? Yes, okay.
Yes, sir.
Perfect. All right, we'll go from there. So I'm grateful to be with you this afternoon. I remember close to 18 years ago, I was able to speak with the family medicine residency there at Ball Hospital when I was first starting out as faculty and trying to blaze a trail for myself. So it's good to be back. I assume you're at the same facility, and hopefully someday in the future we'll be able to do this again in person. This talk I've put together is mostly focused around undescended testis and inguinal hernias. I started this talk a while back. There isn't new information around this, so I think it's still relevant, but it sort of goes about the evidence of why we do what we do and the timeline that we use for it. I've baked in a little bit of basic science to this, but not to bore anyone. I kept it very short and try to keep it as evidence-based as we can. So the two disclosures I have, I'm not receiving any financial support for this talk, and I'm not going to talk about any kind of commercial or investigative device for this material. So my goal is to give you a review of the literature pertaining to the optimal timing for intervention and for referral of undescended testis and inguinal hernias and batched-in hydroceles there as well. And then I want to provide basically the rationale for common inguinal conditions in children. So I want to start off with undescended testis. And please don't look at the numbers here. This was off of an old paper, but I borrowed the image for it. But when we talk about undescended testis, we really talk about two main types, really the palpable and non-palpable testis, and that's oftentimes based upon location. So the patient left of this image is obviously normal descent, and then anywhere extending above that area all the way up into the kidney area would be an undescended testis. When we talk about palpable testis, we talk about those that are actually within the canal. The ectopic sites are the more common locations for the testis, and those include the femoral area, sort of the base of the pubis, and as well as the base of the penis itself. And then retractile testes that are not fully descended or have some type of poor fixation. The non-palpable, let me skip through that. The non-palpable basically are the ones that are either absent testis and there's no testis there at all, or they're up into the abdomen. Based upon a classification in 2007, the vast majority are ectopic. I mean, they're not fully descended, but they're usually can be found. About 10% are actually within the canal, and they may or may not be palpable based upon the size of the patient. And then about 6% are intra-abdominal, and the remaining 5% are just absent testis. Either they had neonatal torsion or they did not fully develop. So when we look at sort of all comers and how often do we see these at premature birth, as we'll get to, there's a impact with regards to their actual descent, and so we see a higher incidence in those premature babies. By about term, it can be 5% of births, and by 3 months, about 1 to 2%. So there's an inference here that some descent can happen beyond corrected age of sort of term delivery. The risks, obviously, as we mentioned, prematurity, if there's any intrauterine growth retardation, any type of excess estrogen exposure that inhibits testicular descent. We've seen this as well as with abdominal wall defects, including gastroschisis, or inadequate production of androgen hormone or genetic component. And those are the most likely causes that we can actually identify. So a little basic science primer here. Work by Hudson really helps define why we have descent of our testis. He's broken this down into a transabdominal phase as well as an inguinal scrotal phase. And the transabdominal phase is often during the first trimester of gestation, and the inguinal scrotal phase is the latter trimester. So not much going on during the second trimester as far as testicle descent. Here's a little cartoon, but what I want to point out here is the blue image is actually the testicle, the brown is the kidney, and the yellow is meant to be the adrenal gland. Obviously, by the 5th week of gestation, we don't have a fully formed abdomen yet, but it's just a cartoon to just represent descent. But by the 5th week, there's a general descent of the testis from the retroperitoneum of the abdomen down low into nearing the internal ring of the inguinal canal by the 9th week of gestation. There it sort of sits there until the 7th month of gestation, where the testis then descends down the inguinal canal and based on into the scrotum. And so we really think of the testis as being an intra-abdominal organ that's pulled externally, and sort of makes sense with regards to its blood supply that we have all studied in medical school. Basically, the interaction here at CSL is the cranial suspensory ligament, and the G is the gubernaculum, but it's basically an interplay between those two structures that allow the testis to actually descend, as the gubernaculum sort of anchors the testis down into the scrotum and through the abdominal wall into the lower scrotum. Basically, as the child grows during gestation, it provides an anchor for that testis and allows the body to elongate while it's actually shortening and pulling the testis down into the scrotum. So there's regression of the cranial suspensory ligament, and then there's an interplay between the androgens and Müllerian inhibiting substance and a hormone, insulin-like growth hormone number 3, that allow for this interplay to happen to allow for normal descent. The inguinal scrotal phase is formed by the invagination of the gubernaculum into a sac-like structure. It forms the processus vaginalis around the testis, and as the gubernaculum sort of inverts, allows the testicle to descend fully into the scrotum, but maintains that fixation low into the scrotum. What we do know about spermatogenesis is that beyond term gestation, the gonocyte turns into type A spermatogonium between the 3rd and 12th month of gestation. We know that this process is inhibited by undescended testis, but we don't know the true etiology of why there's inhibition there. Is it related to the location of the testicle? Is it because there's some kind of problem in the germ cell pool within that testis, or is there a mutation that doesn't allow it to form appropriately and leading to degeneration? We don't know that quite yet. What we do know is then these type A spermatogonium convert to type B spermatogonium between 3 and 4 years of life, and then sort of stay there quiescent until adolescence. And so it's important in the realm of undescended testis treatment that we try to preserve fertility and allow this spermatogenesis process to occur. So does an undescended testis have impact on fertility? And so this is a difficult question to ask, because you got to ask yourself, well, how do you determine fertility? How do you understand the viability of that testis? Is it about a size measurement for the actual testicle? Is it around its volume? Is it do we figure that out because of biopsies, or do we have to biopsy every one of these testicles? Can we determine that by density of future sperm production, any kind of serologic markers, or any kind of paternity? And so you can see if our metrics are one of these categories, it's quite difficult to infer how undescended testis is going to impact fertility unless we were able to biopsy every one of those testicles and see what's going on even before we do surgery on them, which obviously we're not going to get that kind of gold standard information. So there's been a lot of inferences in the data, and I want to walk through that real quickly to give you sort of the evolution of the information that we have. What we assume is that testicular volume is largely composed of the seminiferous tubules, or those tubules that help for the maturation of sperm itself. So we infer that if we have a normal testicular size, that there must be normal spermatogenesis, but obviously there's a big assumption there. Puri in his work in 1990 looked at those individuals who had surgical intervention for undescended testis around 9 years of age, and then they were followed up on average about 24 years. So a very good long-term study. And what he saw was that a cryptorchid testis was much smaller than a normal testis with regards to volume beyond this time of repair. Toscanin in 97 also sort of repeated this experiment and saw that undescended testis oftentimes were half his size in volume with regards to a normal descended testis, but he didn't have any correlation with regards to the age of treatment. It was sort of all over the board. But definitely something happens with the testis when you're repairing them at least by 9 years of age. Hazeselhoff performed 2 studies looking at the histology of these testicles. He studied and focused on the cellular ultrastructure of the Sertoli cells and saw that there's degeneration of the intracellular structures in these testes that were repaired late in life. In 87, he repeated this study looking at the testicles and sort of grouping them based upon age, and saw that the testicles were able to maintain normal histology by 6 months of age, but even by 2 years of age, there was the development of sort of an interstitium, so there's loss of germ cells in the Sertoli cells, and a really complete lack of germ cells of nearly 2/3 by 3 years of age. So clearly, over time, there's a progressive loss of the Sertoli cells and the sperm cell production. Puri also did studies with regards to sperm density and saw that those gentlemen who had repair of their undescended testes between 7 and 14 years, and then studied at 25 years of age, they saw that they had a normal sperm density if it was just a unilateral problem. So obviously you don't know the difference in contribution between the two testicles. If there was bilateral cryptorchidism, that sperm density dropped to 30%. And if it was bilateral, but both testes were in the abdomen, there were no viable sperm cells for those individuals. And then Ludwig also studied fertility in 75 and saw that if they were repaired between 9 and 12 years of age, that they had a normal fertility in about 30%. If they were operated on between 3 and 4 years of age, they had normal fertility about 50% of the time. And 90% of fertility was maintained if children were operated in the first 2 years of life. Now, this data didn't actually pull out where was the location of the testis when they did these operations, whether it was intra-abdominal or down into the inguinal canal. Of all the papers that I was able to reference, there was no mention with regards to the impact of the endocrine producing function of the testis or the Leydig cells. So it's so we don't know what impact there is with regards to undescended testis. So that's presumed to be normal for this, but really no data there. So the theory of surgical treatment is if we can get the testis to its normal location, hopefully we can preserve normal sperm maturation, at least from type A to type B. It's felt that there is a higher temperature in the inguinal canal or into the abdomen that the testis is not used to. And so this would affect the differentiation of the gonocytes and deplete the sperm pool. So surgical orchiopexy, which I'm not going to go into the technical details, but is to try to restore that natural environment. But obviously, if there's an underlying genetic problem or hormone production, it's not going to affect those aspects. So the deductions from all this data largely is normal descent can occur by about 3 to 4 months of age. And that's fully down into the scrotum. That you can salvage fertility if you repair them by 2 years of age. But that we start seeing histology changes in these testicles after 6 months of age and loss of germ cell populations by 3 years. And so largely, if we want to maintain the normal transformative process of the gonocytes, we want this achieved by 6 to 12 months of age. And so ideally, we'd like to intervene in these individuals with undescended testis by 1 year of age. And so you can see the inferences are a little softer with regards to the data that we have, but I likely see that there's not going to be a whole lot of advanced data around this unless we find a study that have volunteers to be able to have testicular biopsies along the process. I did want to mention a little bit around hormonal therapy, as this is a topic that comes up periodically. And basically the assumption here is that there's an abnormal hypothalamic pituitary gonadal axis that's affecting descent and contribution of hormones toward testicular descent. There's been trials with regards to supplying these individuals with beta HCG or luteinizing hormone releasing hormone. And what's been really seen is under clinical trials is that the best response is really for retractile testis, where you may get 20 to 30% to continue their full descent. Unfortunately, this isn't sustainable. And once you come off these hormones, a quarter of them will actually revert and become incompletely descended. There are concerns in utilizing these hormones for supplement that there's precocious puberty, and there might be earlier maturation than normal of the spermatogonia. There's also side effects. And so really these kind of hormones shouldn't be used outside of clinical trials, and they've really sort of fallen out of favor as far as potential treatment. And it's not a therapy that we offer here at Riley Hospital. Lastly, just to reiterate a little bit about undescended testis, is that the malignancy rate for individuals with undescended testis, looking retrospective, is somewhere between 4 to 8 times that for a normally descended testis. What we don't know is what is the problem that's leading to this higher malignancy rate. Is it a problem with regards to the primordial gonocyte, or is it a location? And so we don't know really the cause and effect aspect. What we do feel in our literature is that even though we put the testis where it belongs, that this risk is still maintained throughout their life. It just allows for the testis to be followed appropriately during physical examination. So even if they've had surgery, these testis need to be followed lifelong, or definitely during early and late adolescence. And it's felt that there's a greater risk of malignancy for those testis that didn't even make it out of the abdomen to begin with. And so even beyond surgery, they'll need follow-up for this. I'll probably take questions at the end. I'm happy to do so. So what I want to do is sort of transition here then to inguinal hernias and hydroceles, obviously very similar anatomy here. What we know about inguinal hernias is that there's some kind of arrest with regards to full embryologic development that allows the hernia to develop. That all individuals will have a processus vaginalis, or that connection between the abdominal cavity and the tunica, by 12 weeks of gestation, and this should be completely obliterated by term gestation. It is a process that sort of starts from head to toe as far as the obliteration of the processus vaginalis, and this has been seen to occur to some degree postnatally over a couple months for full closure of that, often seen in premature infants. And basically, what we don't know is what would inhibit the processus vaginalis from completely obliterating. Does it have to do something with the testicular descent, or an impact with regards to the gubernaculum? We really don't know. So with regards to the processus vaginalis, and oops, sorry, this got cut off a little bit, but 40% will often close within the first couple months of life. Another 20% could close by 2 years. But when we talk about processus vaginalis, we're not talking about inguinal hernias. We're talking about that small little communication here that I sort of depict on this netter picture that communicates the tunica from the abdominal cavity. And it is impacted by testicular descent, that if you don't have full descent, you don't have complete obliteration of the processus. But it's not I don't want anyone to feel that hernia sacs could close up to 2 years of age. We're just talking about the processes. So what's the natural history? It still may be present later in life. 20 to 40% will be seen by 2 years of age. In a study that reviewed those with an open processes into adulthood, they followed them for about 5.5 years, and about 12% of those went on to develop inguinal hernia. So there is a predisposition of a processus vaginalis that's patent to maintain the risk for hernia development. And this hernia development was higher than those who were thought that they had a non-patent processus vaginalis. When you sort of look at relative risks with regards to a genetic preponderance, we don't know any kind of genetic factors, but what we do know, if you have a sister of a female patient who had an inguinal hernia, they're very inclined to have inguinal hernias, an 18-fold relative risk, and a brother and sister of a male patient have about a 5-fold risk. So there's something to do with genetic predisposition, though we don't know the actual genes for that. So when we talk about inguinal canals, I like to refer to this picture. It's an older picture that I've used for multiple talks to say what is the full spectrum of what we can see in the inguinal canal. So starting from the left, being totally normal with an obliterated processus vaginalis. The second panel then of a communicating hydrocele just depicts that the processus vaginalis is still open and allows for the egress of fluid from the abdominal cavity into the tunica area. And you can sort of see this ebb and flow of this fluid. An inguinal hernia is just different from a communicating hydrocele based on size of how big is the opening in the abdominal wall and the internal ring that may allow for the hernia or the intestinal contents to come down into the hernia sac. And that hernia may extend all the way down to the testicle, or it may just stop shy in the inguinal canal. And so that's the difference between panels 3 and 4, is that you may see hernia stop at different levels. Hydroceal cord is an interesting finding, and we see this more often than one may think, where the processus vaginalis is obliterated on both the cranial and caudal sides, but it's trapped fluid within basically the canal, sort of what we call the water balloon effect in the inguinal canal. If you're palpating these, you can feel that there's really no extension up into the abdomen. It almost feels like they have a third testicle sometimes up in the inguinal canal. A lot of these are referred because it's felt that that hydrocele is actually an incarcerated hernia because it can't be pushed back in. And so oftentimes these can be figured out by ultrasound, if not by physical exam alone. So a little bit about, just briefly about congenital hydroceles, and we're talking about the ones both non-communicating and communicating. They often will resolve by 2 years of life. The amount of fluid will sort of regress and go away. If we see that they're a communicating hydrocele, where you get a history that the scrotum fills up large, but then when they're sleeping, it sort of goes away, and there's no presence of an inguinal hernia. I've been testing it in there. It's just fluid. We call that a communicating hydrocele. And we often throw those into the same bucket as how do we address inguinal hernia, since the real difference is just a small amount of size difference of whether it's allowing fluid from the abdominal cavity or intestinal contents. The rationale for intervention, as everyone probably knows, is our concerns for incarceration of, well, will that inguinal hernia become incarcerated and lead to a much larger problem? And some really old data from Grossfeld in '89, it was seen that incarceration was seen somewhere between 6 to 18% based upon published studies that have watched the epidemiology of inguinal hernias. What's concerning to us and to those who treat children is that the risk of incarceration is greatest during that first year of life. It's not equal across all ages. And obviously you're talking about a child who can't tell you necessarily that their scrotum is hurting or the testicle hurts. But that risk is at least 30%, where they have the majority of the incarceration occurs during infancy. So when we sort of balance having a hernia versus the morbidity of surgery, this is how I usually teach my interns, but these are the relative risks from published data about what does it take to undergo surgery. So about a 1% recurrence rate, wound infections are quite small. Testicular atrophy deals with, is there violation of this testicular vessels during the operation? Testicular atrophy means there's a significant impact to the blood supply. A decreased testicular size, that may be related to the actual growth of the testis, or it could also represent injury to the blood supply. Iatrogenic cryptorchidism, meaning that we didn't deliver it down to the scrotum at the end of the operation, which should really never happen. And injury to the vas deferens about 1.5%, so quite small. Unfortunately, there is no data around fallopian tubes and ovaries. So females can push their ovary out into the hernia sac, and thus you're sometimes dealing with the ovary and the nearby fallopian tube, but there's no data about what is at risk to those organs for future fertility. So really, we think with those very low risks for surgery, it's really not a question of if we should be fixing the hernias, obviously to avoid incarceration, but when. And so this was looked at by a couple studies. Stylianos in New York looked at a 15-year review of their hernias, over 900 cases of inguinal hernias. What was interesting is they had about a 9% incidence of incarceration. So they had, almost 100 patients go on to incarcerate. And surprising to them was about 35% of them were in those that were diagnosed with a hernia, and some of them were waiting for hernia surgery but went on to incarcerate anyway. And so this leads to our counseling for families, that even if we identify the inguinal hernia and we've seen them in the office, we tell them the signs and symptoms to watch for incarceration, so they know when to seek out medical attention. And 85% of their incarceration events were under 1 year of age. What about prematurity, and what do we do with those individuals? Well, I'm going back to this relative risk profile. And one other risk I would add to this would be the risk of apnea and bradycardia, or related to the prematurity, or them having apnea from the anesthetic. And this is somewhere around a third of individuals. It often is dictated based upon their age at surgical closure, but this is something that we have to talk to families about when we're dealing with a premature infant. These risk of respiratory complications occur in this particular papers were those less than 3 kilos or less than 10 weeks of age. And there's a couple different studies here, but suffice it to say that basically any child who's even a corrected and additive gestational age of 60 weeks will still have a risk of apnea and bradycardia. Now, there's no real guidelines from anesthesia world about when this risk is no longer present. And so each institution really has to develop their own internal guidelines about when can these children be treated as outpatients and when do they need observation overnight. And obviously, as Warner's study depicted, that if you have a history of apnea or a history of respiratory problems, you're even greater risk. On all these individuals, we avoid all perioperative narcotics, both during and after surgery, because that it can increase those risks of apnea. Obviously, the younger they are, the higher the risk for having these anesthesia-related issues. And so in our hands, roughly between 50 and 60 weeks gestation, we're going to observe these individuals overnight to make sure that they don't have any problems with the general anesthetic and having apnea. Right now, it's an overnight stay. We will be refining these with our anesthesia colleagues, and hopefully it'll be about a 12-hour stay for those older but formerly premature infants. So then you might ask, well, what do we do about the NICU patients? And I assume that you rotate through the NICU at Ball Hospital. There are additive morbidity when you're dealing with a premature infant. Obviously, there's anesthetic risks that are inherent to this. There is a greater risk of injury to the testicular vessels because you're working on smaller structures. They're often very large hernias that you have to deal with. They're actually more difficult than the term children because of the size of the hernia sac, and thus there's a higher risk to the vas deferens and the blood vessels. But there's really no standardized approach to when surgeons would intervene on these, and so they usually develop local protocols on how to address this. This was depicted by Antonov, who surveyed all the surgical section of the AAP to figure out when do people fix these premature babies. And 2/3 of them will fix them before they go home from the initial hospital stay. Some wait until they're a little bit older, whether it be 50 weeks or 60 weeks or sometimes when convenient. And a lot of this is depicted, probably the anesthetic support that they have for these locations. You know, if you have pediatric trained anesthesiologists, your anesthesia risks are going to be much less. And so there's really no standard around any of this, but obviously if you're letting these children go home, the family needs to be definitely counseled with regards to the signs and symptoms of incarceration. You know, the latest technology that's evolved over the last 25 years is our ability to put small scopes into small spaces. This really allows us to even utilize the hernia sac as depicted here on the left, where we can use the actual hernia sac, open it up and slide a camera inside and look at the other side to see if they have a hernia on the opposite side. It allows for really high resolution pictures. Here's a picture of a contrail outside that actually shows the blood vessels going through the internal ring. So this is a inguinal hernia that's present at the time of surgery, but it also allows you to inspect the opposite side to see if there's an opening or not. In this case, there's no hernia, so nothing needs to be done on this individual. So in one form or another, the majority of us will look at the opposite side just so that we can address any problem that's there and avoid a future operation if we'd missed that aspect. So my summation with regards to inguinal hernias is that if it's identified, please refer even if asymptomatic. They're not going to close their inguinal hernia. They're going to be maintained and they have a long-standing risk for incarceration. If you identify a non-communicating hydrocele where the fluid's just sort of trapped in the testicle or the hydrocele of the cord, go ahead and watch those. A lot of times those can reabsorb or can be aspirated. But beyond 2 years of age, if they're still there, still large, we'd be happy to deal with those and take care of that fluid. And for the communicating hydroceles, we really lump those in with inguinal hernias and refer repair whenever convenient based on their age. If they've had prematurity and they're less than 50 weeks post-conception, still refer, allow us to time the repair, but we will be keeping those overnight just to be safe for those individuals. So that's all I have on the educational front. I just wanted to reiterate, as was mentioned in the introduction, our group goes to multiple cities across the state to offer outreach clinics that we can counsel patients both preoperatively and postoperatively. I run the clinics at Muncie and Fort Wayne and currently go there once a month. I'm currently at the IU Health Outpatient Center on the south side of Muncie until they get a new home. But happy to see any individuals that you're worried about these kind of conditions or others that we treat. And with that, I'm happy to answer any questions if there are any.
There is a question in the chat, and it's, would you have any tips to differentiate a communicating hydrocele from a non? And is that based on exam findings or ultrasound?
Yeah, I would say that usually on communicating hydroceles, the connection between the scrotum and the abdomen is so small that the resolution of ultrasound may not see it unless they see active fluid going through there. A lot of times I make the diagnosis or a strong inference based upon the history that I get from mom about, does the process come and go during the day? What's going on there? Does it fill up like a big blue water balloon at the scrotum, which would depict more of a hydrocele than any kind of inguinal hernia? And then by examination, a lot of times I'll place the babies on their abdomen, so placing them basically prone for a little while, massage the belly to see if I can get some of that fluid to come out. And then when I flip them over and they're still swelling into the scrotum, you can tell by reduction whether you're pushing intestine back or pushing fluid back. That would be able to help identify whether it's a non or a communicating hydrocele versus a hernia.
Oh, that's a great tip. Another question, as these kids are growing up, is there anything additional we should be monitoring? And what about recurrence? Or, and then another component to that question is any restrictions for sports? Sure.
So if we're talking about inguinal hernias, the risk of recurrence is very low, right around 1%. It's basically negligible. But if they start having recurrence of some kind of symptom or discomfort, that can always be reevaluated. But no sports restrictions for really either of these conditions. For the realm of undescended testis, it really comes down to how difficult the surgical reconstruction was. The majority of them that are sort of palpable or in the canal, those can be brought down quite easily into the scrotum. Some of the ones that are into the abdomen, we use a lot of traction techniques to try to pull them down. And so those need to be monitored because sometimes the traction fails and the testicle wants to reascend. As far as sports restrictions, say for the unrepaired undescended testis, they just need to recognize that anytime that they get hit in the inguinal canal and the testis is against a fixed structure, it could be damaged. But I've not put, instead of giving them restrictions, I just hurry up and try to get them surgically corrected.
Makes sense. Any other questions? You can type them or you can unmute and ask them, whichever you're more comfortable with or whichever is easier for you depending on the device that you're using. All right, I'm going to go ahead and launch the post-test poll. And that way, if you have any questions, you can still type those in, but the poll is live now. About 20, 25 seconds left to finish the poll and type any questions that you might have.
Dr. Ladd, I just want to say thank you for a great talk, and we appreciate your time.
Well, thank you so much. Pleasure to be here. And I think I have another talk the end of April where I'll be back. So hopefully between that and sometime in the future, I could meet everyone who would like input from surgery.
Yes, we have one more comment in the chat that says, just wanted to say this was very helpful. We routinely run into undescended testes and hydroceles in newborns. Yes, so this is really high yield for us and we really appreciate it. And it's nice to know that you're also here in town. What days did you say that you're here?
They're Wednesday afternoons. I can might be like the third Wednesday of the month.
Okay.
Basically, if you have any questions, you can reach out to me. Or just if you send a referral to my office and say you'd like them to be seen in Muncie, they'll be able to schedule it that way. Our schedulers look at really the phone prefix and usually can identify where people are calling from or look at their address and try to assign them appropriately. Sometimes families want to be seen sooner than when I'm in Muncie, so we can definitely see them closer to Indianapolis. I even have a clinic on the north side that saves a little bit of travel time, but as long as families know, they get to pick where they can be seen. But yeah, once a month I'm up in Muncie.
That's fantastic. And so getting a referral through your office is the best way to get a hold of you?
Yes, that's right.
Okay, great. All right, I don't see any other questions in the chat. Anyone have any other comments or questions? Like Dr. Ladd said, we will see him again here in a couple of weeks. Like, what is it? The 20th of next month, I believe.
I think that's right. We're going
to
talk about chest wall conditions, pectus
right.
excavatum and carinatum. So
that's right. Within the next month, we will be honored to have him again. So thank you again. I just want to reiterate our gratitude. So
it's been my pleasure to be with you for this afternoon. I'll see you soon.
Okay, sounds great. Thank you.